Okay, here we go. We will talk about anatomy today. The outline of the whole session. Here we go. We're going to talk a little bit about biomechanics as well. Can you all see my presentation, by the way? Let me just. Can someone give me a thumbs up? Carolina, can you give me a thumbs up if you? Yeah. All right. Super. Thank you. We will talk about biomechanics. We will talk about briefly about injury prevention or reduction and anatomical risk factors. But I'm not going to go into loads of detail with that because we've got the presentation coming out later with Josie, who will go over it in much more detail and be much better than me at it. But sorry, just someone else entered. Here we go. Oh, okay. Here we go. And then we'll talk about hopefully trying to apply some of the anatomy knowledge to coaching practice. In the homework task, I asked you to think about an athlete you've coached or you yourself, and hopefully you've ideally coached someone with a really funky anatomical limitation, which may have changed their lifting technique. I asked you to think, is this something that you think you could change by training, or is this something that's truly permanent? So the example I had in mind was I coached someone once who had a metal plate in his ankle, in his foot, and the dorsiflexion range he could gain, so the ankle mobility range he could gain was set and limited. So it could not get better. As far as I'm aware, it would just be metal on metal, and it would not get better with training. So to adapt that, we had to change some of his. We had to change his start position, let's say, to have slightly higher hips. We had to change it so he could use more of a kind of hip dominant strategy rather than a quad and ankle heavy strategy. We also had to work on his thoracic mobility as well to kind of make up any of the limitations he had. Hopefully you had to think about that. If anyone wants to share, by all means. But this will hopefully get you thinking about some of the ways. Knowing some of this stuff will be useful. I don't really expect, or I don't think it's even necessary to know a ridiculous amount of anatomy detail to be a good weightlifting coach. I think having a good understanding of it is useful, but knowing it to the nth degree isn't probably necessary. But I do think it's really interesting, and I quite like it. So hopefully you will find the same kind of passion for it. If you haven't studied sports science or S&C or sports rehab or physio, some of this stuff in here might be a bit like, whoa, this is too much. That's fine. If anything, well, you've got you'll have access to this so you can go over it in your own time slowly. Again, like I said, not all of it is unbelievably important, or you might not need it for kind of everyday coaching, but very good for background stuff. So it's important to know the kind of structure of the skeleton. We've got various different joints, and again, I actually don't think it's important to know the difference between a pivot joint or a ball and socket joint, but you know that some joints are built for mobility and some are built more for stability. So for example, the ball and socket joint in the hip and the shoulder, it's essentially the ball of, let's say, the femur sits into the socket of the hip joint, and it has ranges in flexion, extension, abduction, adduction, rotation. It's got a big range, so it can move with a lot more range. But as a result, you know, we might find that we're less stable in certain areas because we've got that increased range. It's not always the case where increased mobility means reduced stability, but there is some form of link there. If we look at, for example, even just a hinge joint here in the elbow, it goes up and down, basically. It flexes and extends. There is some rotation as well, but for argument's sake, let's just say it's a straight flexion and extension of the elbow. It's built a little bit more for stability. This would be even more found at things like a condyloid joint, which are basically the joints between the bones of the wrists and the hand. Again, that's built more for stability, and it doesn't have ridiculous amounts of mobility in certain, let's say, joints of the hand. The fingers maybe, but not the actual hand itself. understanding these kind of functions can help you in your sports movements as well. So knowing that, let's say the shoulder joint is, this sounds really silly and obvious, but knowing that the shoulder joint is made more for mobility means, okay, if we have that prerequisite mobility in an athlete, we might look to then start to build their strength and stability throughout the whole range, rather than just blasting them with mobility all the time. If you've already got a really mobile area, it might make more sense to do some more stability work. In terms of what's in a joint, now this is the stuff that, again, isn't massively important, in my opinion, for weightlifting coaching specifically. However, some of the things I will talk about, we will go over. Let's talk briefly about tendons. But essentially, they connect muscles to bone. You've probably all felt or had some form of tendonitis before, or had a lifter with tendonitis. It connects the muscle to the bone. So it's kind of like a bridge between the muscle. If let's say a muscle contracts, it pulls on a bone, and that tendon connects it. That tendon can get inflamed. It can get irritated. But we know that certain training types, let's say isometric training, pretty much any training, but plyometric training, strength training in general, will over time, over a longer period of time, strengthen the tendons and also the ligaments as well. Some of you would have heard of ligaments like the ACL, the PCL, and the MCL in the knee. If you've ever heard of someone having an ACL injury or surgery, you'll know that can take quite a long time to recover, even after surgery. It's useful to know, I would say it's useful to have a basic idea of some of the tendons. I would say as a weightlifter, you're gonna deal with people who have quad and patella tendon. So quad tendon here, and then the patella ligament, or they call it a tendon, but it is actually bone to bone. But these two often get inflamed in weightlifters, and you often see people with tendonitis. And it's just, our sport is a very quad heavy sport. It's a very leg squat heavy sport. And with any repetitive movement that you're doing over and over and over again, if your programming isn't spot on, or if your capacity to recover from the training you're doing, potentially because of lifestyle factors or lack of sleep or hydration, this can lead to irritation, inflammation, or pain in the tendons. Like I said, I'm not going to talk too much about pain because it's incredibly complex, and it's not really my area of expertise, in the sense of there's someone who's going to do a presentation later on who is significantly more qualified than me. So it's a bit above my pay grade, but I'll talk to you about tendons and ligaments and how we can strengthen them, and that will also come up later on in future lectures as well. Okay, so I've smashed out loads of muscles here. I've done it for lower body, upper body, and trunk. I'll talk about some of the important ones. So for the quads, for example, thigh, front of the thigh, there are, let's say, four quadricep muscles. What's important to know is that one of them, the rectus femoris, crosses the knee and the hip. So if you wanted to, it extends the knee and flexes the hip. So if you wanted to stretch the rectus femoris specifically, you would have to do something like, if you can imagine a couch stretch where your back is against your leg is against the wall and you're in a kind of a lunge position. If your hips are really far back and they're shifted against the wall, and that hip is actually straight, yeah, that's a great stretch for the three vastus quads. The monoarticular muscles, the biarticular, or the crossing two joints, the rectus femoris, would need the hips to shift forward to bring the hip into extension. Again, for a lot of you, essentially, is if you know the quads are in the front of the thigh, then you're in a good spot. If you know what they do, if you know that they extend the knee, happy days. Same with the hamstrings. The bicep femoris, there's two heads, short and long head. That's the one that's biarticular. The semimembranosus and the semitendinosus, they just pull the foot up to the bum. So if you see like a hamstring curl, for example, that would be biasing the semimembranosus and the semitendinosus. The bicep femoris would need your hips to come into flexion as well. So you would need to be in a more hinged position, essentially. Again, not massively important, but I find really useful and interesting to know. The glutes, multiple heads of the glutes, multiple medius, maximus, and minimus. They control hip extension, so the leg coming backwards behind the body, and then frontal and transverse, so side to side adduction, and then transverse or rotational work. The adductors, there's 5 of them. Again, not important to know all the 5. However, when, for example, the adductor magnus, big muscle here, has a posterior side to it, which is, or posterior, behind the line of grab, the center line. When you are in a deep squat, the adductor magnus is actually a very strong hip extender. So, now this is important for weightlifting because a lot of the time, if you see someone who, when they're standing up out of a deep squat and their knees come in and their knees valgus and track it inwards, then it could be the fact that the adductor magnus is that's in its strongest position. So it will also adduct the hips and it will bring the knees together ever so slightly, but it will extend the hip, i.e. getting out the bottom of the squat. So that's really important to know, is that the adductors will play a big role in hip extension, especially in that deep flexion range. This is the example I gave of the biarticular muscle, so calves, your soleus and your gastrocnemius. Your gastrocnemius is biarticular, so it's stretched by dorsiflexion and knee extension. So if we wanted to stretch the calves, it would make sense for us to stretch the calves in knee extension. If you have time, you could do it in both. You could bias the soleus by stretching your ankle or flexing your ankle with a flexed or bent knee. If you wanted to bias the gastrocnemius, which is a biarticular muscle, you would need the knee to be extended or straight. So if you're doing that kind of standard calf stretch where you're stood on the edge of a step and one of your heels is dropping with your legs straight, that's going to bias the gastrocnemius stretch more. The hip flexor group, it's important to know that the rectus femoris would include in the hip flexor, but if you're looking at the 3, iliopsoas, pectineus, sartorius, the iliopsoas, the iliacus, and the psoas major, the iliacus here and the psoas major, the psoas attaches to the spine. So to stretch the psoas, for example, you would need to be in hip extension and you would need to be in a lateral flexion of the spine as well. Again, it's not major important. It's a really small thing. Again, I find it really interesting to know. And what I will say is it's something that's kind of cool that if you're saying to like a normal lifter who's not interested in anatomy at all, say, oh, your hip flexor tight. Okay, let's do this hip flexor stretch. Oh, but actually, if you know that one of the hip flexors, the psoas major, is attached to the spine, so we should also do this. It just makes you look like you're an absolute god among humans, and that you know so much. It could be good as a way to kind of sell yourself and make yourself look way better without having to know too much information. So we will talk about some of my injuries just because I've got some good MRI pictures that you can see. So let's just look. So when I tore my hip flexor and adductor a year and a half ago, pretty much in this exact moment on the slide here, maybe a frame later, or this is pretty much spot on when it happened, and it was this side. And this is the you can see here, this white part is just blood. It's a hematoma. So this end of the dark bit is where the muscle should be attached up here. Obviously retracted, triple avulsion of the rec fem, adductor longus, and gracilis, hip flexor / quad, adductor. It was caused by this rapid load under a stretch position. So I was in a super stretch position, too low to the ground, basically. And the adductor, I actually think the rectus femoris tore off the bone, and then the adductor longus and the gracilis tried to kind of hold it, and then they wasn't strong enough because they're not the strongest muscles. The rectus femoris is a very strong muscle. So basically the muscle then retracted here, started to fill up with blood. I got a nice juicy bruise, which I think I probably put in the slides at the end somewhere. this was caused by stretching the hip under load. Let's take, for example, the rectus femoris. So this position here is, you can actually see front to back. If you look at the rectus femoris on the front leg, it's basically the muscle that goes straight down. Oh, it's not here. Oh, it's in front of it's the quad muscle basically. It's a line of quad muscle here. Here, it's short here. Yeah, but it's a bit longer there. So it's shortened in this hip flexion position. Now here, you can see in this leg, the hip is actually quite extended. And I'm in a bit of a hip flexor stretch there. So no wonder it was under so much strain and tension. That's when it just had enough and pulled off the hip. So it attached, unattached itself here. So it pulled this way. And there, because this knee is flexed as well, it's just a little bit extra stretch at the distal end rather than the proximal close end. The gracilis and the adductor longus, again, that's a hip flexor as well as hip adductor. So I think I was potentially in a slightly wide stance where I kind of jumped the foot back and to the side, so it just caved in a little bit and it just snapped the hip off. But that's a good example of why my rectus femoris tore off, but my other quad muscles didn't, for example, because the quad muscles are only attached here rather than up above the hip. So that's where knowledge of the biarticular muscles actually does come into play, and you can actually get kind of funky with it and use rehab, especially in a rehab setting, or if you've got someone that's had something crazy like this. My rehab specifically for the rec fem would look different to other quad muscles. Fun. Okay, posterior trunk. I'm not going to talk massively about this, but the erector spinae group help you. Basically, there's 3 of them. They all extend the spine and they laterally flex the spine. A good, just something that I was told recently, the acronym ILS, I love to stand, is what they do. Basically, they help you stay upright. Stands for the 3 erector spinae muscles. I love to stand. Longissimus, spinalis, and someone will jump in with the I. Iliocostalis. One of them. They basically help you stay upright. The lats, big thick muscle here, they attach around the front of they kind of attach here in the front of the shoulder. So they start at the back, they come all the way around the body and attach up here. So inside the humerus. So what it can do, because it attaches here, it can actually pull the shoulder down into adduction. It can also pull the shoulder back into extension and internal rotation. So when someone says, oh, my lats are tight, this butcher's block stretch where they're here and they're coming up is actually quite a good one, because it does the opposite ways. It flexes you. So if what it does is cause extension, to stretch it, you need to pull it into flexion. So you're pulling the shoulder into flexion, you're pulling the shoulder into slight external rotation. Slightly externally rotated. So when you're doing a butcher's block elbow on the bench, and you're trying to stretch your lats out with a stick, it actually makes sense to hold the stick slightly wider than your elbow so you can come into some external rotation as well. And then the rhomboids do, there's 2 of them. Small one, minor, big one, major. Pull the shoulders back. So that's an important muscle for, let's say, stabilizing the bar overhead or off the floor. And then there's the trapezius, the traps. Again, there's a superior, there's a small, there's a high, medium, low one. Basically what they do is they pull the shoulders back, up, down. Each fibers do different things. Again, they're kind of muscles that stabilize the back, hold you in an upright position or an erect position. It's important in our sport, obviously. There's not a lot of time in our sport where we're really flexed over. A lot of everything from the floor is open. The front rack is open. Overhead, we want to be open. We don't want to get closed off too much. So having strong muscles here is important. We've got the anterior trunk muscles, so the muscles at the front. Rectus abdominis is basically your abs. So this is the 6-pack / 8-pack muscles. They flex the spine, so they do the opposite of the erector spinae. They pull the chest towards the hips. And PPT, posterior pelvic tilt, so they, yes, they pull your hips under. So if you can imagine someone standing and they're sticking their ass out, that's anterior pelvic tilt, where they're pulling the hips back. Posterior pelvic tilt is they're pulling it, they're tucking it under into that kind of what we would consider a suboptimal position for like a front squat or a back squat, where we're tucking the hips under too much. The obliques rotate the spine, they flex the spine, they help posterior pelvic tilt. The transverse abdominis is more, it's less superficial to the it's more inside you essentially, and that's raising intra-abdominal pressure, so bracing essentially. I have added in my favorite muscle of all. Whoa, pyramidalis here. It tenses the linea alba, which is the kind of fascia inside the six-pack line. It does absolutely nothing useful in weightlifting, but it's absent in 20% of people, which I think is super cool. It's my favorite muscle. If you can remember that in 3 weeks' time, I'd be well impressed. Pyramidalis, absolutely pointless muscle, useless, absent in 20% of people. The people that don't have it have no difference in functional strength at all, but I think it's really cool. Upper limb muscles, deltoid, so your shoulders, you've got 3 heads. So again, it provides 3D movement. Just think of it as anterior, posterior, and lateral. I think there is some more evidence coming out now that there's more heads, but it doesn't matter. They cause flexion, extension, abduction, external and internal rotation. Triceps and biceps, awesome muscles, makes your arms look big. Essentially what we're looking at is flexing the elbow for biceps, extending the elbow for triceps. What the biceps will also do is flex the shoulder. So it's quite important. I have seen a lot of overhead, let's say shoulder impingement type issues, which are actually down to biceps long head, which is, I'll put it here, both heads. Bicep brachii here, the long head attaches above the shoulder. So that's what pulls the shoulder into flexion. Can actually just be kind of an irritated bicep as well. It's not always the shoulder. And then the triceps, similarly, they all three extend the elbow, but they also sometimes assist they assist in shoulder extension because they attach not only here, but they attach above the shoulder, so they pull the shoulder back. Rotator cuff muscles, we've all heard of these. They all assist in basically stabilizing the humerus, the upper arm, into the socket of the hip. So they don't actually do too much in terms of movement. Like they do move external rotation. One of them elevates the shoulders. One of them abducts. One of them actually internally rotates, but they're not the major movement muscles. They're more stabilizers. They pull the shoulder into the socket essentially and create stability. So with that being said, when you see people doing rotator cuff exercises where let's say we're doing like an internal rotation, it would make sense that let's say that we're doing an external rotation. If you're just using a dumbbell that's like a flat weight, it's not necessarily going to work the rotator cuff muscles the way you think it would. I believe they would actually respond really well to isometric exercises and then stability type exercises where you're kind of off balance. Anytime you catch a bar, they're going to be working really well. Anytime you pull off the ground, they're going to be working hard. But when you see people doing rotation work with just a dumbbell, it's not going to work too well because of the resistance profile is not going to be. If you use a band, for example, it's going to be significantly better. Because it's actually going to have tension throughout the whole range. If you're just flapping around with a dumbbell, it's not going to do too much. Okay, here we go. So we know now some of the muscles. We know that some of them flex and extend things. They abduct and they internally rotate. They externally rotate. Movement planes, again, not massively important in the sense of it's not going to change really how you coach a snatch, but it's good to know. The 3 planes are sagittal, frontal, and transverse. Sagittal basically means up and down. Frontal means side to side. And transverse means rotational. So this, let's say that, for example, this sagittal plane that's coming directly down the human body there, directly down here. If you think of it as a pane of glass, that if you go through, you're going to break the glass. So it's everything that's just up and down, basically. However, you will then find you'll be able to categorize these movements into pretty much all rotational movements. So if we look at I'm going to show you an example later, but a lot of times you can pair movement into these three. Flexion goes hand in hand with adduction and internal rotation. This is more about producing force. It's kind of you're getting into a position to produce force. So it's more about yielding to force. Extension, let's say if we're pushing down, extension actually goes well with adduction and internal rotation. I think I've got some of these wrong. I'm going to look over that again. Don't worry too much about this. I'll talk to you about it later. But coaching applications, knowing some of these is actually quite useful, less so in weightlifting, but when we're looking at things like athletic movement. So if we look here at, let's say we look at Usain Bolt's front leg, his lead leg comes into flexion. And if we look at Asaf Apal, there'll be a little bit of internal rotation because his pelvis is twisted there, and adduction. When they're pushing away, the trail leg, the hip comes into extension, abduction, slightly outside the body, and externally rotated. So they kind of go hand in hand, and it's the same with the arms as well. Bolt's forward arm is shoulders flexed, and this is Powell's from the front. So Powell's adducted, so the movement's closer to the body, and internally rotated. Abduction is coming away from the body. Adduction is coming in. His backwards arm is extended at the shoulder here, pulled backwards, and it's abducted, so it's pulled out, and it's slightly more externally rotated. They go in pairs, and here's in triples, and here's a good way again. So this is that example I was given earlier about pushing with the legs, pushing in from the squat. You might find some internal rotation and abduction. Again, that's a force producing position to be in. That is a position where you can produce the max amount of force. You're using your, let's say, your adductor magnus, your adductor that extends the hip. So just because it comes in doesn't necessarily mean it's bad. This kind of catch position, let's look at his shoulders, for example. He's more kind of forward here. In this position, he's more externally rotated as he's yielding to the weight. He's holding the snatch. Liu Xiaozhen is holding the snatch overhead as he's yielded to the weight. He's not necessarily producing loads of force to move the weight. He's trying to brace against the weight and stop against the weight. So knowing that will influence the movements, especially in field-based sports and like, let's say, sprinting and locomotion. In the weightlifting, it's a bit more thinking about it as propulsion or force production, and then yielding, i.e. force, let's say stopping the weight or yielding to the weight. So the big man, Isaac Newton, he was the first ever weightlifting coach. He described 3 laws of motion: law of inertia, law of acceleration, action, reaction, law of reaction. Essentially, they basically suggest that a barbell is not going to move unless we apply force to it. Yeah, that sounds obvious, but it's an object at rest is going to be heavier than an object in motion, which is why sometimes if you feel like, let's say you're lifting from the blocks and the blocks are really high, it can sometimes feel really heavy because you've got not only got to break inertia and extend in a split second, you haven't got as much time to accelerate, law number 2, as opposed to, let's say you're lifting from the floor, you've built up some momentum, you've got to the knee, and it won't necessarily feel as heavy, even if it's the same weight, because you've built up some, you've broken inertia already, it's already moving. The law of acceleration is the force acting on the object is proportional to the rate of change. So basically, the heavier the bar, the more force you need to achieve the same acceleration. So if I wanted to accelerate, so if I was using a barbell velocity tracker, if I wanted to accelerate or move at, let's say, a squat at 0.5 meters per second, it would take significantly less force to do that at 50 kilos than it would 250 kilos, for example. Because the barbell is so heavier, you have to put more force in to accelerate it to the same level. Law of action is the fun one. When we apply force to the ground, we have a resulting force transfer through the body. Every action equal and opposite reaction. So the harder we push through the floor, the harder, the faster and the more weight we can move when lifting. So that's why a lot of people use the cue, push the legs through the floor, because they're not thinking necessarily about moving the bar, but they're thinking about moving the body, and the bar will stay connected to you, but you get that reaction. So the harder you push through the ground, the faster the bar can move. Thinking about the kinetic chain, everything we do starts from the feet and hips and trunk, and it builds it. A lot of our power comes from our hips and our torso, and it goes distally, so it goes towards the arms and legs. So having strong legs, having strong glutes, having strong bracing is very important. It's important to know that things like ground contact with your feet is actually quite useful. As much as I'm not a huge believer of like the whole tripod foot thing where you need to have like your big toe, your little toe, and your heel in contact with the ground, but like I think it's people like talk about it way too much, and it's not always as deep as that. However, there will be some force lost if you're in a really awkward foot position. Let's say you're lifting your toes up, for example. You're not going to be, and you'd be surprised. It sounds really simple and obvious. You would be surprised, especially if you're coaching people who are not natural athletes and you're coaching people who are, older with no experience of sport or anything, that they will do funky stuff with their body that you would never expect. Like they will try and pull a heavy deadlift with their toes off the ground. You would be surprised. And that's just the way it is coaching normal people, non-freak athletes. This stuff is important, but we know now that force generated at the ground, like I'm saying, pushing through the ground, will transfer throughout the body into the barbell. If there's a weak link, like a chain link fence, if there's a weak link, obviously you'll know it will be an issue. This is where the biarticular muscles come in again. So they kind of, a lot of the times, if you have a biarticular muscle, that's what it's transferring the, let's say, the rectus femoris crosses the knee and the hip. It will then, that force going through the kinetic chain will go through the knee, through the hip, via the rectus femoris. This is what I should have put this at the start. I don't know why I didn't put this at the start. This is the stability and mobility model of joints. The blue ones are more stable. The red ones are more mobile. This, again, makes intuitive sense, but you would understand why. Let's say if you're, what's a good example? If you're not super mobile in the ankle, you might see someone squatting in a way where their lumbar spine, their lower back, their lower spine, flexes loads under load. And it's not always an issue with the whole butt wink thing, but if this set of joints is inherently made for stability, we probably don't want to be moving it through massive range, especially loaded, because it's made for stability. So we'd need to address mobility at the hip or the ankle, for example. There's not many people I know who don't have mobile enough knees unless they've had a surgery. Most people can bend their knees relatively well. It's a stable joint. So if they're very weak in the quads, let's say, that might be an issue. If they're losing stability here, they might have to compensate somewhere else, for example. And it's the same with the shoulder and the elbow. You see it more at the elbow where people aren't mobile enough to lock out. So they're kind of, and I'm not talking about people who can't lock out. I'm talking about people who are actually just a bit immobile. Then their arm becomes, they lose a bit of stability because they can't lock the elbow solidly. So they do lose a bit of stability there because they're a bit more passive and the muscles are having to do the work rather than the joint. There are some people who don't look like they're fully locked out, but it's actually just because they can't lock out. So that's their lockout. They're actually, sometimes you'll see them hold crazy weights overhead like this because they're actually quite stable. They just it looks a bit off. It doesn't look super mobile. Okay, so injury sites in weightlifting, we all know, we've probably all been there. Shoulders, lower back, knees, wrists, for example. It's the areas that are either compensating too much for other issues. So that's why you'll see a lot of lower back issues if someone can't either get into a deep squat with a decently neutral spine, or if their thoracic maybe isn't extended enough, they might have to compensate elsewhere. There are certain anatomical vulnerabilities, like I suggested earlier. Guy has a plate in one of his ankles, can't flex the ankle as much on one leg, so he's going to be super twisted. There's stuff to do that you can do around that. Looking at that joint model, it might be that, okay, if his ankle is meant to be a mobile joint, but it's now not, we need to make something else more mobile realistically. So we're going to either influence his ankle mobility by giving him shoes with a higher heel, so he has fake mobility, or make his hips way more mobile, or make his shoulders more mobile, for example, that we can compensate and still get into a decent position. And what I will say is this guy was actually really good at doing his rehabby stuff. And he actually ended up getting into really good snatches and overhead squats where you wouldn't actually think that this guy could hardly move with one of his ankles. So it can be done. There'll be some limitations where it can't really be done. But that's a good example of someone who, yes, the ankle in the red was made for mobility, but that basically had to become a blue, had to become a stability. So he had to find more mobility somewhere else. Okay. So if you look at the anteroversion or retroversion of someone's hips, a good test is, you'll see this a lot with you'll see it more with kids. Funnily enough, if you coach kids, the crazy kind of anteversion. But if you just get someone, it's crazy. But if you just get someone to lay on the floor and just relax, you'll find that some people's legs will naturally fall open, like this retroversion, and some people's will fall in, like this. You won't see this as often, but you might still see it. And then a lot of people's will just be normal and there. And this is to do with how the femur, the thigh, sits in the hip bone. Okay, so if you're naturally more retroverted or turned out, you might find that your squat position, let's say, is just so much better because you can just sit into your hips a little bit more. You've got more, you're already in an externally rotated position. So if anything, you've got more internal rotation, so you can actually sit into a real deep squat. If you're in this position, for example, and both your feet are naturally turned in, it's going to take a lot of effort to try and find a way where you can squat, especially in weightlifting where you're very open. I think I've got a good picture here. Perfect example here. Super retroverted, and I know he is because when I ask him to lie on the floor, his legs literally flop to the side. Como, and then Cece here is more introverted, so turned in, and she has more of a internal rotation bias. Obviously, she's able to do it because she's really mobile and her hips are mobile. Because it's just, but she will never squat like this, really. She can because she's got the mobility, but she won't be super strong there, I don't think. And vice versa. If he did that, he would explode. And this is just because it's the way they're naturally built. This guy, more externally rotated, more open. CC, more closed off, more internally rotated. And this does come down to this hip socket depth and level of anteversion and retroversion. This is also apparent. I'm not going to go into detail on this because I'm genuinely still not. This is still kind of new to me, but I still don't actually fully understand it. So I'm not going to lie to you and say that I do. But there's some evidence coming out now and more recently about infrasternal angle, which is essentially the angle here of the lower ribs, and the angle it is towards the sternum. this clunky boy here, it's these ribs, the lower ribs especially, are actually quite pliable. They do actually move, especially when you in inhalation and exhalation. So when you inhale, they actually externally rotate. So your ribs actually open up a little bit to create more space, and vice versa. When you exhale, your ribs and actually your pelvis as well a little bit internally rotate to squeeze air out via the diaphragm. If you're someone with a really wide infrasternal angle here, a thick boy, you could say, you will be more biased in that exhalation range. In the article, which I would tell you to look up, from Connor Harris, I found it on internet. He says that these guys are more leaning towards more lumbar lordosis, which is like that anterior pelvic tilt, and internal rotation, so they can find more ER, I believe. And they might be more geared towards muscular movement, whereas the narrows are the opposite, and they're more compressed and they're more elastic. So I'm not going to go into more detail because that's still getting to me, and I'm still trying to figure it out. Again, it's one of these things where even if this was completely true, it wouldn't change it. It wouldn't change how we coach someone, really. We still want someone to snatch. We still want someone to clean jerk. But it might stop you from forcing someone like this to squat more like this. Because this person is going to... This might look more aesthetic in terms of what we would expect to see a front squat or a clean to look like. But it might not be a strong position for this person because they're built more internally rotated, for example. Vice versa, trying to get him to be like this would be more of an issue, okay? Bam. The big picture, there we go. That's that blood bruising I was telling you about, that hematoma. People say that must be painful. Genuinely, no. Wasn't painful at all. It looks painful, but it genuinely was not, because it was off the bone. So there was nothing there to have pain anyway. But that's just blood pooling, essentially. So blood hemorrhaging and in that space. And then the reason it's down here is just gravity. So it all sits up here, obviously, and then over time with gravity, it's seeping down the leg. And the blood, I actually ended up with a bruise down here on my calf before it fully went away. So it was obviously, the injury was up here, but it ended up the blood down here, which is really cool. Makes for a cool photo. I showed these to as many people as I can, just kind of proud of it. Tendinopathy. So common injuries and weightlifting. Again, I'm not going to go smash this, but because we're going to get talked about it later on. Tendinopathy, looking at inflammation, inhibition around affected joints, probably knees, potentially shoulders, potentially elbows. I've got get a lot of times, especially with heavier guys who are less mobile in the front rack, getting into this kind of funky position here, and it gets a lot of strain on the elbow. So you get that kind of golfer's elbow style tendonitis in the flexors of the elbow. So especially if they were to do like a pull-up or something and just really overuse that, and not overuse it, but flex that really hard, they might kind of get irritation there. Lower back pain, you'll see this quite commonly. Sometimes it's just unspecified. Sometimes it can be, let's say if you've got like a herniated disc, can be really painful for some people. They have herniated discs and have absolutely no symptoms. So it's a bit of a broad spectrum of things it can be. But regardless, if someone's got lower back pain, it commonly will happen for a lot of people in weightlifting. Again, I'm sure Josie will talk about that more. Wrist pain, hand pain, again, I don't think many people know what it is eventually, because no one wants to get MRIs because they cost a lot, and a lot of the times they don't really tell us anything important. They just tell us that there's something there, but the rehab is not going to change too much. And then freak accidents like this, which can happen, but they're reasonably catastrophic. So tendinopathy, this is inflammation usually caused by spikes in intensity. So if you say to someone, we're going to go with the knees, we're starting on squats 3x2 at 80%. We're going to do that for 4 weeks. And then on week 5, we're going to go 10x10, 80%. If they don't get tendinopathy, I'd be like, that's surprising, because that's a massive spike in intensity volume. So when you're programming people, small changes, Does it need to be every week? You can, and I'll talk about this in the programming lecture. When you program for someone, let's say you give someone 3x2 at 80% snatch 1 week. The next week, if they do 3x2 at 80%, they're still going to get a training benefit. I don't know why we think that because they did it last week, they're going to be no benefit doing it the week after. We have to make it higher volume or higher weight. We can do the same thing for weeks and weeks and weeks and weeks and still get a benefit. I found, by the way, this white stuff, I believe, is the inflammation. This is the this will be the patella here. This will be the femur. This will be the quad, the patella tendon, I believe, which was the issue I had it in. This is actually bursitis, which is, I think, inflammation as well. But yeah, very painful. The tendinopathy, just if let's say it's patella tendon, inflammation, irritation, your quads will be kind of overactive. In terms of your CNS, I believe, will want to kind of inhibit them from using. So you need to maintain the areas around it. This CNS component is, if you've ever had tendonitis or bursitis for long enough, you'll get to a point where even when you know there's no structural damage, just sitting, unlocking the knees and just sitting ever so slowly into a squat will cause you pain. And a lot of it isn't, not to say it's not physical pain, but a lot of it is CNS inhibition. And it's your body still basically being, okay, I've been in pain every time I bend the knees for weeks and months. I've now kind of learned that behavior. So we need to do some kind of CNS, central nervous system retraining, where we retrain the brain to accept load and accept range under load. This is the way I would do it. The biggest thing is, I'm going to skip this. The biggest thing is just load management. For every injury that we talk about, the biggest thing is load management and making sure they're sleeping well, eating well, drinking hydration. And if they've got a back injury, giving them 10x10 deadlift probably isn't going to help. But giving them 5x2 at 50%, if it's not painful, that's a good example of how load management is useful. Not blasting them, but just doing something that stimulates them enough so they get a training benefit and training effect without making the symptoms worse. If you're ever coaching someone that's in pain, the pain is the gauge, and you just listen to the pain, basically. So if you're doing something and it hurts, probably don't keep doing it. If it kind of is uncomfortable, it's like a 2 out of 10, probably not the end of the world. But if it's like a 10 out of 10 sharp pain, if you don't stop, it's your fault. You're an idiot. But load management is the key, specifically for tendinopathy. This is the kind of steps I've used: is start with long duration isometrics. For example, a wall sit up to 60 seconds, up to 90 seconds, no added weight, long duration. A lot of this is to do with that retraining the CNS, the brain, and the kind of let's say call it like the excitable, what's the best way to put it? Like the systems that create tension, teaching them to actually not squeeze all the time and actually kind of relax and squeeze into it. And essentially teaching the brain that holding tension in your legs and your knees is okay and not going to kill you. Then move on to overcoming isometric. So that's something like a isometric mid-thigh pull, where you're pulling against a bar that is not going to move. Maybe it's under the safety pins, but you can do max force, but you can do it fully under your control and you're not moving anything. So it's isometric, you're not moving, but you can apply max force. Now that would come after this because it's more maximal. This is long duration, up to 90 seconds, like an RP4, RP3. This is coming up to kind of RP10, the overcoming ISO, but it's 5 seconds max. Then you're getting onto things like, once you're doing this without pain, then you're going on to tempo work. So let's say tempo squat, slow tempo with a pause, for example. So you're not bouncing up the hole and causing loads of jarring movements. Then you're going to add load, and then you're going to go on to So you're kind of building up the strength again, building up the control, and then you're going to go on to the RFD, the rate of force development. And that's when you start getting into things like plyometrics and jumps and sprints and maximal lifts and Olympic lifts, for example. Obviously, within each step, there's loads of other steps, but that's a good little framework you can use for tendinopathy. Lower back pain, in general, this, I believe, this white bit is the herniated disc. I think so. This is my lower back. This, I assume this is actually the muscle I was talking about earlier. Actually, I've not thought about that. Maybe not. This is my lower back. This is disc coming out of the spine where it shouldn't be. It should be in there. And it's pushing against a sciatic nerve. So that's one example of lower back pain that could be caused by this herniated disc. The only thing is we actually don't know, because who's to say I haven't had that for years? But years before I had the pain. I don't know, obviously. It doesn't really matter at the end of the day. But it's, like I said, it's these injuries can range from seemingly debilitating to being completely asymptomatic. So maybe I had this for 5 years and had no issue, and then suddenly I flared up my back, and then I thought, oh God, I should get an X-ray or get an MRI. And then you see it and you think, oh, it must be that. At the end of the day, it doesn't matter what it is, because the rehab is the same. What I've found, though, is that this, any lower back pain, whether it's functional, physical like this, or if it's just I get more of a mental thing, a lot of times it will cause tightness in the areas around it, so the hips and the glutes, and for me personally. So again, large CNS component, being able to kind of relax them and not hold loads of tension in other areas might make it better. The things that have helped me more recently and helped other people I've coached is just making sure that the core work you do is varied and let's say holistic. Not just abs, not just obliques, not just lower back, everything. Isometric holds, planks, Chinese planks, or reverse planks. So that's isometric work. Things like side bends, heavy side bends, light side bends, twisting, bracing, Russian twists on a GHD, stuff like this, as varied as possible, toes to bar, stuff like that. What I would say is, as hard as it is, because I've had back pain which is completely debilitating, where I can't get out of bed sometimes, it's so bad, and I feel like I can take some kind of abuse and be okay. I've had it where it's so bad that it's I can't move. Ideally, we don't take prolonged bed rest. There's no evidence that's going to, well, there's probably a lot of evidence that says that isn't helpful. We know that doing something is better than doing nothing. Yes, I'm not saying if you've got a herniated disc, do 10 by 10 deadlift. Probably isn't smart anyway for anyone. But moving, we'll go for a walk, will help you out. I think there's no evidence suggesting that it won't. There might be a day or two where you can't. Yeah, fine, valid. But we're not talking about spending weeks and weeks and weeks and weeks. If you've ever known anyone who has, for other medical reasons, had to be on bed rest, I only know of 2 or 3. You know that a lot of the times they can actually get things like herniated discs just from sitting all day, or just laying in bed all day unsupported, because their muscles aren't doing anything. Everything becomes lax and weak, and the worst thing you can do is get weaker. So ideally, and this is going to be a difficult thing to do, because to tell your clients this, because if you've got clients who are misinformed and they think that, oh, I'm in pain, so I shouldn't do anything, it might be quite hard to change their point of view if they've had long-held beliefs that have been, they've thought this for decades. I'm sure that the physiotherapist who's listening to this currently in the chat, in the Zoom call, will be resonating with this. That's actually one of the hardest parts of the job sometimes, is convincing someone to train. Yeah, and it's about reducing the training, and it all comes down to load management again. And this is similar to this. So even when this happened to me, doing something felt more useful than doing nothing. So the very next day, I was doing isometric work, single leg, let's say split squat, iso holds. I didn't know what it was at the time, so I didn't want to do anything ridiculous, but I did something. I'm 100% convinced, 100%, 101% if it was possible, convinced that me doing the isometric work immediately after helped my recovery outcome and sped it up slightly, even if it was by a few weeks, sped it up because I didn't have as much. By the time I went to surgery, I didn't have as much muscle wastage. I wouldn't have had as much weakness and CNS weakness. In the surgeon's report, the surgeon said my hip flexors were unbelievably large, that they had to make 2 incisions, not 1. So stuff like that will help, and that will help your recovery or your client's recovery as well. So in terms of freak accidents, they're a bit more rare, obviously, but if you can identify common technical issues, for me, it was the low split in the jerk. Had it for years, and then it just got to I got strong enough that I got to a weight where it was too much, and who knows, it might not have been that. It could have been anything. It could have been that I was slightly, I don't know. It could have just been my damn luck here. It could have just been unlucky. But things to look out for are limit taking massive PB attempts, especially if the technique's a bit crazy. I don't expect anyone to take a PB attempt and have perfect technique. But if you've got someone that's got a really wild technique that just looks dangerous, probably stop, but they're really strong, maybe probably limit them taking like 10 kilo jumps to a PB, just because if it's going to happen anytime, it's going to happen then. I found just from experiences in lift, it happens more in lifters who are very progress very quickly. So you hear a lot of things about like, oh, the tendons adapt slower than the muscles, and this is true. The tendons, for example, take longer to adapt than muscles. So having a rush slowly mentality and that slow progression method is going to be more sensible. We know this. It can also happen in those who have degenerative disorders. So if you're someone that has, let's say, something like EDS, which can get worse and worse and worse, and it's some kind of joint laxity that's just genetic or medical, yes, you might be more at chance for popping the elbow in an overhead or popping a knee or something, because you just have inherently genetically less joint stability. Okay, nearly there, guys. Nearly there, I think. Right, so I wrote some of these down. I was on the train, and I was thinking about how different anatomical issues can help you in actually when it comes to coaching. So let's say, for example, limb lengths to start with. Certain people's techniques are going to have to be different because of their limb lengths. You can't change the limb length, so don't even try. And certain people will have to have their hips higher up in the start position, for example. Certain joints need to be more mobile than others. This must be accounted for, ensuring safety. If let's say if one of your knees is, or one of your ankles is really mobile and one of them isn't, it's not to say that you're going to get an injury. I don't think it's as simple as that, but we might as well try and balance them out. We're not going to get so obsessed with they have to be perfectly balanced because that's ridiculous, but we're not going to just leave one to be shit and just never try and make it better, are we? What is it? Body sensation awareness, self-correction techniques, mindful training. So getting someone, a lot of the times when you're coaching someone, using cues and constraints to get them in the right position is a good tool to get them feeling the body. I've actually found quite a lot of success with things like getting someone to feel let's say their quads. So maybe I'm going to get them in a start position. I'm going to drop their hips slightly. I'm just going to hold them there. I'm just going to wait. Once their legs start shaking, I'm just saying with an empty bar or something, they're in a start position, holding that. Once their legs start shaking, I'm like, okay, Jill, can you feel your quads? And then she's, yeah, I can feel my quads. Okay, great. So you felt your quads, let's use them. So, and then that might be something that when she goes into set up next time, if she's someone that really lifts her hips up really high and just uses her back, she might get to that position and be like, okay, this was where Benedict was torturing me. I'm going to go. I'm going to go there. I'm not going to go here. I'm going to drop my hips down. I'm going to load my legs. I'm going to feel my quads, and then I'm going to stand up and go. I've used cueing and bodily cues in terms of the post I made recently about keeping the bar heavy on your neck or your collarbones. Giving an athlete a cue that's with their own body and not the bar, I think is quite useful. So if I've got someone who's pressing early in the jerk and using their arms, it actually might be counterintuitive to be like, okay, don't press the bar, don't press the bar, don't press the bar, don't press the bar. Because all they're going to think about is not press the bar, and then they're going to probably do it because that's all they're thinking about. It might be more useful to say to someone, rest the bar here on your collarbones, on your shoulders, as long as possible. And then they're just going to keep it connected to their chest. And when they drive up, it's going to stay connected to them. Their connection and their drive is going to be a lot better. It's going to be straighter. It's going to be more, the arm's going to whip into place because there's less tension. And using that cue, that bodily cue where you're, and again, similar with the quads example I gave earlier, stops them from thinking about the bar itself and makes the cue a little bit more internal and less external. If you think even as simply as, I'm going to be better at controlling stuff that's closer to me than something that's further away from me, because the signals have to go from my brain all the way down to my hands to where I'm thinking about not pressing the bar. I'm not saying it takes ages. It obviously doesn't take much longer. But if I'm only having to think about what's happening here, and this just works itself out, happy days. So that's a good example of using your kind of body as a cue. Oh my word, how much? Oh, sorry, two more slides. Oh, just giving that. So anatomy feedback, basically. So understanding people's body movements, targeted movement adjustments. So again, I've given an example of giving anatomical feedback, let's say here, to change your technique and enhance your efficiency. And then enhancing, we know that by, let's say that earlier example I gave of retroversion, if I make the guy who's really externally rotated try and squat with the internal rotation, the chances are it's going to be less safe and less optimal for their movement patterns and their mechanics. All right, here we go. These concepts, I find them really interesting. You might not do, you might do. Like I said, it's not important to know every single little thing. But knowing a few little things are quite good, not only to make you look good in front of the client and stuff like that, you might laugh at and think, oh, that's silly, but it does build trust. In one of the biggest things that's going to help a client, or a lifter progress is them trusting the knowledge and the experience of your coach. Because if you can imagine your coach and you're doubting them, if I can imagine I'm doubting my coach, everything I do is going to be a bit more lackluster and a little bit more, I'm not going to put as much effort into it because I don't really trust it. I'm a bit tentative. If I just put my full trust in my coach, I'm going to go harder. I'm not even going to think about it. I'm just going to smash it. So stuff like that is important to not only make you look good and sell yourself, but to enhance and build that trust. Knowing certain anatomical things as well will help keep your lifters safer. Obviously, you can't fully get rid of a chance of injury. There's always a chance of injury, especially in a sport like weightlifting. But if we can reduce that risk, then that would be fantastic. And improving their performance. So knowing certain things, like knowing which muscles are biarticular, the common muscles and common injuries that get that happen in weightlifting, and knowing, let's say, a common movement pattern that could be down to an anatomy fix. If you're someone who is the earlier example of the anteversion of the more internally rotated hips, their squat is going to look very different. It's going to look less aesthetic traditionally, but it might not be an issue. Obviously, there's limits. But if you see their knees valgus slightly at the bottom of a squat, it might be quite useful if there's someone, and I've had this before, actually quite a few times, where someone's shown me their squat and there's someone who's very anteverted, and they'll say, oh my God, Benedict, I can't stop putting my knees in. All I'm thinking about is knees out, knees out, knees out. And I can't not do it. Well, it's like you're fighting against your own body there. Like, your body wants to be in that internally rotated position. That's where it produces force. And that's where I see a lot of people who, when they're doing like squats, they'll put a band around their knees. And for me, it's stopping you from if you're someone that naturally internally rotates a little bit more and you're forcing yourself into external rotation, all you're doing is forcing a movement pattern that you're not actually very strong in and applying loads of load to it. By all means, work on the weaknesses, but probably if it's somewhere you're so bad at, you probably shouldn't be doing your max squat with that constraint, because that is a constraint to the point of it's going to stop you actually moving more weight and applying more force. It's not a constraint that's going to help you move better necessarily. It might look better according to a textbook, but we know that humans are all different. Not all humans are Liu Xiaozhen. Not all humans are 75-kilo Chinese men who have been lifting since they were 12. And not everyone's going to have perfect genetics. So knowing these differences can be useful in optimizing someone's performance, limiting their injury risk, making you look good, making the trust between you and your client better. And it's good to know it can help you out when it comes to injuries and devising specific exercises for someone. I might try and find an example of that. If you want to work a really specific muscle, so like I said earlier with the soleus and the gastrocnemius, the calf muscles, if someone had you just knew, for example, they had a weak gastroc, you might train it in a separate way. All right. So the next presentation will be on technical models of lifting, which some of this will actually apply. I would like you to think about 2 different techniques. I've probably given you many already, actually. I probably have. Think about the picture of CC and Combo, the anteverted and retroverted person. Give examples of 2 different techniques that could both be considered correct. Ideally, 2 techniques that are vastly different to each other, but the same thing, as in the same part of the lift, but they're both very different. That could actually, technically, you could say these are actually correct because of this reason. So there needs to be a rationale for it. But I'd like to see that, and I'd actually like to hear some of them in the. I'm going to ask it in the chat actually. Right, that is. I'm going to stop sharing. Oh, I might have already stopped sharing. All right, good stuff. Hopefully that was useful. If you've got any questions, please let me know.
Thank you, Benedict.
No, my pleasure. My pleasure.
Michael, thank you so much.
Yeah, no worries.
Thank you.
Have a wonderful evening.
Cheers, mate. Thank you.
Bye. Have a wonderful evening. Eat lots of food. Get some sleep. Thank you, Rachel. Big Jordan.
Thank you.
No, my pleasure, mate.
Thank you.
Thanks for
really,
coming.
really helpful.
Thank you.
It was enjoyable. I was going to ask about
Mate, go on.
William, but I left it.
Oh, you can ask now. I'm still recording, so I'll put it in the chat anyway.
Fair. Also, I didn't know whether it was okay to say his name or not. And also, I don't know
don't say it again, just in case. But I know who you mean. Go on, ask the question.
So Marcus was telling me about him. That he has like struggles in the jerk because of his anatomy, but I don't know. Like that's all he told me, right? And so I was going to ask.
This guy's a great example. So this is a guy who has what's it called? It's called like a pigeon chest thing. You know, okay. where it's almost like the clavicle is kind of in. You see it in the chest, right? It's really collapsed in, and because of that, then obviously he's more internally rotated. He can't be as open, and I think that's why this particular person is very, very strong in this flex position. You see him catch a clean and then bend over basically horizontal and still be able to make it because his anatomy is such that he is more internally rotated here. So over time, over years, over 2 decades, his back has got really strong, and he's more rounded. His spine is always going to be a little bit more curved. Now he's done a lot of work actually on his chest himself because of this issue, his chest didn't develop as well. So he's done a lot of bench press, a lot of chest stuff, and that's actually got better. So he's got a bit more open, actually. Now, when you see him now, it looks a bit more, you couldn't tell. Whereas when he was a kid, you could really tell. But that's a really good example of someone that, I think that's a good example of someone that's always going to have a limitation, but similar to my guy with the ankle plate, there's workarounds where he can get better through other ways. Yeah.
Okay, yeah, I was curious of like what, because you said like, okay, we don't have mobility here, so we had to find it somewhere else.
Yeah. So for him, if the thoracic in that mobility stability one was one of the mobile ones, so the thoracic is actually quite mobile. Because of that issue here, he actually does have quite a lot of flexion mobility, but not loads of extension. I can tell you why that is actually, but basically because he's already sat like this. So it was just about him finding trying to get more extension in the spine, in the thoracic, but then he actually worked a lot on his shoulders. For him, I think it was shoulders, yeah. So it would be at a point where, okay, my jerk's like this because of my chest. I need to work on getting that shoulder extension and getting to here. So to be fair, it'll be chest as well, won't it? So he actually developed his chest, got his chest stronger in a full range. So he yeah. So that's a good example of that, actually.
Yeah, I was just curious about it, just because Marcus told me, and then like you see his training, and he has like very clear strengths, right?
Yeah.
So I was just curious of how you had to like work around that with coaching.
He's a good example of that ISA thing where it could be that he's more suited to certain things. Deadlifts, unbelievable. Front squats, surprisingly good because he can just flex loads and still not lose the bar. But snatches, big struggle. Because of you can't be like this in a snatch regardless of how strong.
Yeah, it's impossible.
Yeah. Whereas in a clean, you can be like that and still somehow make it. So, yeah, that's a good question. I'll remind everyone in the chat.
Okay, cool.
All right, top man.
All right, thank you, mate.
No worries.
Have a good evening.
Recording.